Hello, good morning or afternoon. Welcome to today's policy discussion, where we will be presenting the findings of our year-long Global Mental Health Matters project. We're here today because more of us are living longer lives than ever before, and as our lifespan increases, we're unfortunately spending more time in poor health. Yet, despite the significant and indeed growing burden of serious mental health issues around the world, mental health care access and support does remain unevenly distributed across different age groups and socio-demographic cohorts. And our new report, which we're here to talk about today, Mind the Age Gap, is focused on how we make mental health matter across the whole life course. Esther's going to talk a little bit about the findings, but the picture isn't great. Our report highlights that current mental health policies aren't really fit for longer lives. 1 in 8 of us will live with a mental health condition. Half of us will live will live with some form of mental health condition during our lives. So this is more likely as we live longer. And access to therapy services and treatments remain difficult for many, whilst internalized ageism and stigma can compound the issue as we get older and reduce our likelihood of being willing to seek out proper mental health support. Uh, but actually what we've done with the report as well, and the work is highlighted that there are some opportunities to address the challenges we have, and we would like to work with all of you on how we do this. The report, as Esther will highlights a number of policy opportunities for us to discuss. I should say Boehringer Ingelheim has funded ILC to produce this report. ILC has retained editorial control of over all written outputs, and actually the webinar is an ILC has been entirely ILC managed. So this is an ILC event exclusively. During today's webinar, we're going to be hearing from a range of experts and speakers on how we can ensure that mental health policies and services reflect all of our needs as we live long lives. So following their thoughts, we will be able to bring in some of your questions. I hope we'll have some decent time for questions, but please use the Q&A feature to submit anything you may want to ask. So I'm going to pause immediately and pass over to Esther, who has led on this, to talk a bit about the findings in the project. Esther.
Thanks, David. Thank you to our excellent panel of speakers, and thanks again to Boehringer Ingelheim, who, as you said, kindly supported this report and programme of research. So throughout this work, we looked at mental health policy across 5 target countries, which were China, Germany, Japan, UK, and the USA. And we wanted to look at mental health policy through the lens of 3 serious conditions, which were major depressive disorder, PTSD, and schizophrenia. And as David has alluded to, overall, we found a pretty bleak picture. There's a growing burden of poor mental health and suffering, and we don't see the resources and investment required to meet people's needs for healthcare. Many of the expert stakeholders that we spoke to across these 5 countries and others frequently referred to older people, generally baby boomers, and younger people, the Gen Zs of the world, as very distinct and still diverging groups in terms of their understanding of mental health and their overall mental health literacy. While there are meaningful differences between generations as serious mental health is destigmatized and we collectively build more mental health literacy, this sort of ageist binary, as we will see, undermines our ability to effectively understand and respond to this growing burden of serious disease. Now, the first finding from this program of work was this barrier of ageism throughout our longer lives. This binary between young and old is reflected in who can more easily access treatment and referrals and who faces more barriers. And it undermines the person-centered approach to mental health care and healthcare more broadly that is lauded by many countries and international organizations as the gold standard of mental health care. The second finding, that 4.2% of GDP is lost to mental illness every year, which is, for context, is greater than the level of borrowing amongst OECD countries within the early days of the COVID-19 health emergency in order to cope with the impacts of the pandemic and lockdown restrictions. So what we are losing on an economic scale is absolutely vast. And the impacts in our next finding are no smaller on people too. So around the world, 155 million years are spent in disability each year as a result of mental illness. And this has an impact on our work, our volunteering, our capacity to care, spend, save, and do all of the things that really matter to us. If we average out this 155 million years, it means that each one of us around the world would spend 1 week in disability. And hopefully that does a little to really set out what we would struggle to measure that we are currently losing to mental illness. And the fourth finding, to summarize from this, is the urgent need to increase workforce capacity and retention. So we've alluded to the economic losses and how resourcing and infrastructure have not sort of kept up with the burden of demand, with the burden of disease. But we see that the gaps in workforce that we will return to in just a moment are really hamstringing our capacity to do more on mental illness around the world. So just to set out a little bit more about what we found, the first table here is taken from our report. We've already highlighted that ageism has no place in mental health care and in policy making or commissioning, nor in practice. And we see from this table that the burden of mental ill health is fairly evenly spread across generations, with the exception of under 10s. So approximately around 14% of people of each age bracket within this chart are experiencing a mental health condition at that stage in their life. We also heard from a pediatric psychiatrist that ageism could also be a barrier to young children's care. So these under 10s that we can see, because it is assumed falsely that children cannot suffer. And this sort of these assumptions around who does and who could suffer did sort of permeate many of the conversations we had and a lot of the findings that we made. Now, the second table illustrates the varied workforce structures across our 5 target countries. This workforce, of course, without whom no mental health care is possible. Now, common themes that emerged across all of the countries we studied was that clinicians and services are generally overwhelmed and under-resourced, with consequences for staff retention and job satisfaction. Now, on to my final slide of our recommendations. We found that a key opportunity in 2025 to really move the needle on serious mental health conditions across the life course are this year's UN high-level meetings, which focus on NCDs, and bringing mental health conditions in line with other NCDs that are broadly physical illnesses is a really crucial next step to embedding this as a priority for policymakers and health systems around the world. We know that health systems need to be investing more than the current 2 to 10% of their health budgets on mental health here in the UK. 10% of NHS funding, our National Health Service funding, is spent on mental health, which is approximately 20% of the disease burden. So we see that clear mismatch between resourcing and the scale of the problem around the world. The third is an emphasis on person-centered care across health systems, which account for individual preferences, cultures, beliefs, and other characteristics. What this can look like in practice, for example, is talking therapies that are more flexible than the current 50-minute weekly sessions that are very common in health systems around the world, and requires health systems and clinicians to be much more flexible and be able to be flexible to the needs and preferences of their patients. The final recommendation is to take a life course approach that David alluded to in the introduction to meet people's needs throughout our longer lives. As we are living longer and demographic change continues to reshape our societies, this will become more crucial to manage the current and future disease burden of mental illness and allow all of us to work, volunteer, care, spend, save, and make the best of these extra years. Thank you very much.
Great, thank you so much, Esther, I know that we could have talked for hours and hours on the report and findings because the project has emerged from events that we have done across the world where we've talked to real experts, including some of the people we've got on the panel here today. So we're going to invite some of our panel now to add their thoughts and contributions, and I'm going to start off. We're very honoured to have Professor Akiyama joining us from Japan. Japan is one of the areas where we went to Japan to talk to some real experts in this space to get a feel for what was happening in Japan and what was happening in Japan. Professor Akiyama also has a global context interest, though, as he is president of the World Federation for Mental Health. So, Professor Akiyama, can I ask you to kick off?
Thank you. Thank you, Patrick. Hello, everyone. And it is my honor that I can speak on behalf of the WFMH at this seminar. First, I commend the report, which is factual and thorough, and an aging society's main challenge is one theme of this seminar, and it is, as the report says, a life course approach is a challenge, as I see. For youth population, policymakers should make deliberate efforts so that youth will have more opportunities to have direct communication and interactions with others, especially with the peers. For the for the working age population, as primary prevention, opportunities to improve communication skills and problem-solving skills should be provided. As a secondary prevention, annual health checkup, mental health checkup should be provided for early detection and early intervention. As tertiary prevention, relapse prevention and resilience building programs should be provided to the people who want to continue working with mental illness. For the aged population, good home care should be provided. Best practices in Japan include relapse prevention program for people who return to work with mental illness and home visit treatment and nursing care for the aged population. For all ages, the purpose of care should be recovery. Recovery requires capacity. The purpose of providing group opportunity to use is to build capacity. Relapse prevention program, the purpose is help the working age population with mental illness to maintain capacity. Home care for the aging population seeks to provide opportunities to them, for them to continue using the remaining capacities. The report is good, but we can improve the strategy. Last October, I attended the Mental Health Forum at the WHO headquarters. I said to Deborah Kestel and Dr. Tedros that WHO should appeal to the government that people with mental issues are not a cost to society, but an asset. We can discuss loss and burden, but we should correctly estimate the contribution of the people with mental issues are making to the society. And people with mental health issues do have various capacity, and with inexpensive support program, they can improve their contribution. As mental health stakeholders, I think it is our responsibility to show the government and the people what gain they can obtain from the investment in mental health. And I guess this will be the faster and easier way to persuade the government to spend more money for mental health. End of my speech. Thank you.
Great. Thank you so much, Professor, and some great ideas there. And I liked the idea around the opportunity of reframing. It's really important that we do think about that. Our work has shown that if you're looking at older people, for example, older people are responsible for a third of all spending, a third of all work, a third of all consumption. And if we keep people healthier, we have a very direct evidence that that results in more spending and more work and more volunteering and more caring. So there's a real direct benefit for keeping people of all ages healthy from an economic point of view. I'm going to pause there, and I know that our professor had to leave us because it's about 2 o'clock in the morning in Japan, I think. So we are very grateful for him to join us. So thank you, Professor Akiyama, and pass over to Marion DeVoe, who is a health policy analyst at the OECD. Marion, what do you think?
Thank you, David. Well, first of all, I would like to congratulate ILC for this important report on making mental health matter across the life course. The reports highlight the burden of mental health in terms of life years with disability, impairments in social and occupational activities, and the economic cost associated to mental ill health. It makes emphasis on the life course approach to mental health, from identification of early signs of mental ill health to older ages, and calls for addressing ageism and stigma around mental health conditions. The report also presents a novel analysis combining data from the Healthy Aging and Prevention Index, data from the World Health Organization, and from the Institute of Health Metric and Evaluation to examine the mental health and healthy aging in the context of cultural, social, economic, and political factors that Esther presented in her presentation. I would like to reflect on 3 elements of the report. First, the report puts great emphasis on taking a life course approach for mental health. And this approach is largely aligned with the current work at the OECD on mental health. Over the life course, people face several periods of increased vulnerability to mental ill health. And these phases can include specific periods such as childhood, adolescence, but also life events, for instance, becoming unemployed, the death of a person close to us, or the onset of a disease like cancer. It is indeed essential to identify these periods of increased vulnerability in the life course to be able to deliver effective preventive and healthcare interventions at these crucial periods. The second point I would like to make is about the statement in the report that says it is crucial that health systems are able to capture the burden on mental ill health with robust and comprehensive data. This is clearly an area where the OECD integrated mental health approach can help. This OECD approach builds on the work carried out across various parts of the organization over the last decade. Specifically, at the OECD, we aim to track and report indicators identified in the new benchmark for mental health system, a report published by the OECD in 2021. And we are now currently complementing this database with new data collection across various areas of mental health. And we will aim to release some data by the end of this year. The last point I would like to make is about the low access to mental health care and support. The report states that in the UK, only 1 in 6 old adults with depression receives a diagnosis. So this figure corroborates with findings of the OECD, although our estimate slightly varies. We estimated that in adults of all ages, only a third of people in OECD countries get access to the mental health care support they need. The main barriers to access to mental health care include health system related barriers, such as low provision of care, insufficient workforce, but also personal barriers, such as stigma around mental health condition and mental health care, which prevent people from seeking the care they need. To overcome these challenges, the OECD is currently producing a series of case studies for assessing best practices in mental health promotion and prevention. We have selected and evaluated 11 best practices intervention, ranging from facilitating access to psychological therapy, to peer-based programs to train people to deal with a person with mental distress or in a crisis. We also include school-based intervention to build social emotional skills. And we also include interventions spanning across multiple sectors to prevent suicide. So more information on this will be available soon as we will release a report in a couple of months. In this report, we will also evaluate cost effectiveness of the different interventions with findings, so as I said, available in a couple of months. Finally, I would like to conclude to congratulate again ICL for this important report, and also thank you for the opportunity of sharing the OECD views and the future work on addressing mental health challenges. Thank you.
Great, thank you so much, Marion. And I know you also have to leave soon as well. Just to say, I think from an ILC perspective, we're clearly very keen to continue to collaborate with OECD and help you promote your work in this area. So let's carry on the conversations afterwards. But thank you very much. We've had a research input and an economic input and a practitioner input. We're going to move now on to policymaker or politician input. And I should say we've got 3 really highly respected politicians who actually have a very strong interest in this area and indeed expertise as well. So clearly one of the reasons ILC does, the main reason we want to do work in this sort of area and across our whole agenda is because we're here to change the world, and actually we need people who are about to speak now to help us do that. So I'm going to kick off by passing over to our next speaker, which is MEP Dr. Andreas Kulcha, and we're very delighted to have you here. So thank you for joining us.
Thank you for having me. And I would like to thank you all for inviting me to these prestigious discussions about the topic is very close to my heart because before I became a surgeon, I worked as a psychiatry resident doctor at Semmelweis University's psychotherapy clinic, and during the med school, this was one of my favorite topics because I really believe that our mental health is a very important part of our general health, and it's very important to have discussions like this. And also, I would like to tell you my congratulations to the report that you have been working on. It focuses on very important topics such as ageism and stigma and the significant and growing burden of mental health issues. And I would like to highlight the importance of mentioning the healthcare workforce shortages in the field of psychology, psychiatric nursing. Furthermore, the lack of funding that member states allocate to these issues. We witnessing these problems across Europe, and in the European Parliament, thanks to the researchers and the reports like yours, we politicians and also the advisors are aware of the fact that this is a silent pandemic in the world and in the European Union. It affects all age groups with their specific characteristics, difficulties. Therefore, I highly support the suggested life course approach. And few words about the mental health actions in the EU. The Commission released a communication comprehensive approach to mental health in 2023. Also, the Parliament published our own initiative report on the topic, furthermore in the Healthier Together project launched by Commission. Mental health is indeed considered as a fifth NCD. The Council conclusion on the mental health of young people says this topic as a priority. Therefore, I would like to add on that. During the COVID, I worked in a COVID department, and I witnessed these really heartbreaking situations in our hospitals, the devastating effect of the pandemic, and now we are witnessing the collateral effects of the pandemic, because we see that the age group between 16 to 25 adolescents, the loneliness is quadrupled. Every fifth person in this age group has a mental health problem, and every fifth death caused in this age group is because of self-harm or suicide. And I also raised this issue during the SANT committee meetings, because now we have a SANT Public Health Committee as a standing committee with a full legislative power. I think it's a big step because now we can put some pressure on the Commission. We can raise these issues. We can be more vocal. Because till now it was only a subcommittee part of Environment, Food Safety, and Public Health Committee. So I'm very committed to work on this. And as your report mentioned, it's very important that 80% of people that were diagnosed with mental health conditions about 26 had symptoms in very early ages, even at age of 11, which also stressed the importance of the prevention. So I think it's crucial that prevention and early detection networks to have these networks in primary care, schools, and workplaces, and these to be developed across member states. Finally, that what we can improve as a former health literacy and communication specialist, because it was my hobby or my second job when I worked as a surgeon, because I created a health literacy improving TikTok channel and got more than 300,000 followers and 100 million views, and I told many times about mental health. But I really believe that communication is also key. Communication and education, not only in schools, but also in social media. We also have to use these new tools to reach the vulnerable people in our societies. And these days, the misinformation is spreading with the speed of light on social media, and I think it's our responsibility. And I'm talking now as a doctor and a policymaker, member of the parliament, that it's our responsibility to keep the trust in science. Also, I think bit of responsibility on professionals, researchers, but I don't want to put this pressure on everybody. But together, I think we can really cover this communication field and reach people. And the idea of the mental health here would, I think, perfectly serve the purpose of the science-based advocacy of mental health. We must educate also people, teachers, caregivers, and also physicians for improved early detection and wellness to enhance resilience in our society. The Commissioner of Health and Animal Welfare, Mr. Varhey, stated that youth mental health would be in focus. Therefore, we really hope that that we can achieve some improvements during this new mandate, and I think this is perfectly in line with the Council's conclusion. Therefore, I would like to call for a youth mental health action plan during this mandate. I know that we had action plans, but now seeing the effects of COVID, and I'm not talking about just about the disease, but that this generation was separated because they had no real connections and social experiences during those years. So I think it's very important to focus on that, and with that action plan, the EU maybe would be able to fund and provide professionals guidance and good practices for member states to build a more prepared and resilient healthcare on all levels in field of mental health. So I can say that it is one of my main biggest priorities during this mandate to move things forward a bit and achieve some results. I know that we cannot change the world in 2 days, in 2 years or 5 years, but we can start something, and maybe together, professionals, policymakers, patients, organizations, we really can start some changes in a positive way. And I think I talking too long, so thank you very much. These were my thoughts about this, and thank you for your report.
Thank you so much. And I should say, whether it be ILC UK or our work with the ILC Europe that we lead, I'm sure that we would be willing to support anything you want to do around making the Youth Action Plan a reality. So let's keep in touch about what we can do to help through our networks. And also thank you. I think I had read about your work on TikTok, and I think it's really important that we go to where people are, and social media is often seen in a really negative way. We did some analysis a couple of years ago using actually Facebook, and we found that it was a very powerful tool to get, if managed correctly, to get the right sort of messages to right people. It doesn't always have to be negative. And there's in addition to you may know there's a Romanian doctor on Facebook who's managed to create a page and has 1 million followers to sort of dispel some of the anti-vaccine myths. So it's a really important role to have professionals who know what they're talking about on those platforms. So thank you for that. I'm going to pass on now to Baroness Ritchie, who sits in the House of Lords in the UK and was formerly an MP. So Baroness Ritchie, what's your perspective on the discussion?
Thank you, David. And I want to commend you and the authors of the report, Mind the Age Gap, making mental health matter across the life course, and of course the organisers of the webinar. Firstly, I would like to declare an interest. My late parents were psychiatric nurses in Northern Ireland between the 1940s and 1970s, in an environment which was intensely institutionalised for those who suffered from mental ill health. But and I'm glad to say that the changing nature of an approach to mental ill health developed over those years and led in a greater emphasis on community care. But the great deficit was the growing number of people in the older age groups who continue to suffer from mental ill health and their lack of accessibility to mental health services, either in a hospital setting or in the community setting. And I think those are some of the issues that you're trying to address in this particular report. We are now in an environment where direct government and community action is required, as the report states, to meet society's mental health care needs. That has also created problems in communities where a significant number of carers are feeling overwhelmed and unable to get the support they need and are entitled to social care services themselves as they battle with mental health conditions. So that is one of the cumulative impacts of community care. The report contains some startling findings. 1 in every 8 people around the world currently suffers from a mental health condition, and many of us will experience such condition at some stage during our lives. The report further states the scale and burden of mental ill health has vast global economic impacts. And what is more startling is that the report states that we're living longer, the burden will only increase in the coming decades. The bottom line is that we as a global world are failing to meet the current demand for mental health care, and that managing serious conditions throughout longer lives will require even more staff, greater system capacity, and increased investment. And we need to look at the human cost of communities, a factor that became more acute during the COVID-19 pandemic, and since that time. We saw children, young people, and individuals right across the age gap feel the trauma and social isolation from lockdowns and the fear and panic of the actual pandemic itself. We must not forget that the wars in Ukraine, the genocide in Gaza, and the general Middle East, including Israel, only increase mental health and post-traumatic disorders. And could I also say that the decisions of the current incumbent in the White House on US aid, and also how that impacts on our global output in terms of dealing with all these health emergencies, including mental ill health, will further cause mental health problems. Because today, in the last few minutes, the Prime Minister has announced a reduction in development aid from 0.5 to 0.3 from 2027 in order to increase defence spending. So that is part of the consequences, all of which will have impacts on mental health provision across our age gap, and also impact on provisions throughout all government departments. So what must happen? There must be greater levels of investment in the World Health Organization and no diminution of this organization by world leaders. There must be a systems-led approach leading to investment in population mental health. I agree with the recommendations in the report. There needs to be a utilization of the 2025 UN high-level meeting on non-communicable diseases to bring infrastructure for, investment for, and the recognition of mental health conditions in line with other non-communicable diseases. And in the UK, the National Health Strategy Plan for 10 years and the Darcy report all must align with the recommendations contained in this report to ensure that a person-centred care, intervention and pathways to improve outcomes and accessibility for mind the age gap will ensure that mental health matters across the life course. And we must use this as the opportunity. And there is a salutary reminder, David, in the report that meeting the needs of people of all ages is a moral and practical imperative, and failing to do so will deepen inequalities and compromise the future of our communities. For my part, I will be lobbying government ministers and my colleagues in the House of Lords to ensure that mental health and how we provide for it in terms of medical, physical and social interventions matters across the life course. We're looking for the government to implement policies that place the treatment and care of mental health at all levels and at all age groups at the centre of policy making in health and social care. And furthermore, and finally, the UK government must work with other governments in the EU, United Nations, and via the World Health Organization to address and deal with the challenges faced by the mental health issues of this century across the age spectrum. Thank you.
Brilliant. Thank you so much, and for actually the passionate advocacy as much as anything else. And I see that there is a question about USAID in the Q&A, so we may come back to that as well. But I would encourage others on the panel, others who are listening in, to add any questions into the Q&A. We've got one other contribution first. We're delighted to be joined by Lord Layard, who is the co-director of Community Wellbeing Programme at LSE's Centre for Economic Performance, and a real expert in this area. And if you haven't, let me do a plug for Lord Layard's fantastic book on happiness, which I would encourage you all to buy if you haven't already. But actually also to say, for those of you who don't know, ILC's Global Healthy Aging and Prevention Index uses a measure of happiness as one of our 6 measures of successful aging. And please do have a look at that. Lord Layard.
Well, I saw that, and thank you for that, David. I think this is a great report, and of course, the background to it is the shocking fact that if you are physically ill, you typically get treated, and if you have a mental health problem, you don't typically get treated. And this is a worldwide situation. And it's shocking for 2 reasons. First, the humanitarian one, but also, of course, the economic one. So on the humanitarian front, I spend my time working on people's life satisfaction, as David mentioned. And if you are looking in advanced countries, at any rate, for the most important causes of low life satisfaction, the number 1 cause is mental illness, especially having been diagnosed ever in your life with anxiety and depression. This is a much more powerful predictor of whether you will have low life satisfaction than poverty. And we absolutely have to get into politicians' mind a different concept of deprivation. We have got to get people to recognize that being deprived of the ability to enjoy your life for whatever reason is deprivation. So that's the first thing, humanitarian. But the economic thing, of course, is incredibly important, as is stressed in the report. I have, of course, I'm an economist, so I have used that argument. And when we were pushing for a proper approach to adult anxiety disorders and depression in Britain in about 2007, we, of course, used the economic argument, because that, unfortunately, lands the case better, more powerfully than the humanitarian one. And we argued that if we had a proper psychological therapy service for adults with depression or anxiety disorders below the critical level, which is covered by the existing mental health trust, but if we had a separate service for all the others, that largest number of people with mental health problems, we would have a service that paid for itself. And in fact, it's now been proved that it pays for itself within the first 2 years to the government, in the sense that the government gets back more in money through extra taxes and less welfare benefits than it laid out in the first place on the programme. just say a word about the program, because I think this is of interest around the world, and it's now being copied in 6 countries, and I think another 6 are thinking of it. This is the program now called NHS Talking Therapies. How it was developed was a training program to train people in the evidence-based programs recommended by the government's specialist body recommending treatments in the NHS. Start with the therapies, then train people to deliver the therapies, roll out services in which you're partly training people and partly using people already there, and build it up in a systematic planning way over a 15-year period, so that now, after 15 years, we're treating 700,000 people a year. We measure the outcomes at every session, so we know that 50% of those people are recovering. And the productivity of this kind of service is very high, because it gets isolated from the other support which people need, but which they need to get from other sources, support with employment, housing, and so on. It isolates it. It's a self-contained service led by a psychologist or psychological therapist. This is a very important point. With people who do nothing other than provide this therapy, and they're treating something like 65 people a year. That's of course one reason why the economics work out so favorably. We have subsequently made the same case for young people, children and adolescents having mental health problems, including conduct disorder. And that is now being rolled out, covering half the country. It's called mental health support teams in schools. That's, I think, also something which other countries could be interested in. And we're now pushing for a third service for people with addiction, personality disorder, and severe mental illness. And I hope that we'll get that in the upcoming spending review in Britain. Our allies, and I think this is a relevant point for everybody in this conference, our allies are the people in the Ministry of Finance. We get more support from them than we get from the people at the top of the health service. And that is something which I would strongly recommend everybody engaged in this campaign to cultivate the people in the Ministry of Finance, because they have a different view of what are the priorities in the health service, because they recognize that health can be a very important contribution to the nation's economy. Just one final point. How are we going to get this out on an adequate scale worldwide? There is huge progress in these digital treatments. My colleague David Clark has got a digital treatment for social anxiety disorder, which works as well, 80% recovery, the same as in face-to-face. But they work much better if they are embedded in a health system where there is also a therapist who is in contact with the patient by telephone, but for perhaps 1/7 of the amount of time in the normal face-to-face treatment. I think this is going to be the force which will have a huge impact on mental health worldwide, and we should stand behind it. So very good luck with your campaign. I think it's a great report, and what an opportunity at the UN.
Thank you so much, and we'll open to questions. So please do put your questions into the Q&A. Whilst I'm sort of free reflections, I suppose, on the economic side. Clearly, there are huge economic challenges in the UK just because of demographics. We're likely to lose 2.6 million workers over the next decade, so we need to keep people healthy. So there's a very strong argument for that. But actually also, I think one of the things that we find quite frustrating as an organization who does use the economic argument, that actually we have to. So we did a piece of work a year or so ago where one of our recommendations was that we shouldn't have to justify fun on the basis of an economic cost effectiveness, that actually purpose and fun and well-being should in itself be something that is valued, and we shouldn't have to prove an economic benefit for it. But that might be a challenge to convince our finance ministers. And then finally, on the digital point, it's where I know we've got George McGuinness on the line from Innovate UK, and Innovate UK have been supporting some quite significant and interesting projects from a UK point of view on digital interventions in this space. And I hope the UK can play a part in leading the way. So let me jump to our Q&A, but perhaps first I'm going to jump back to Esther to see if Esther, if you have any reflections or thoughts on any of the comments so far.
Well, first of all, I'd like to echo David's thanks to all of our speakers. We really appreciate your time and your reflections on the report. We're glad it's been so well received because it was such a fascinating program of work and such an opportunity to learn so much about an area that is too often pigeonholed, where we see ageism and an intergenerational war often at the center of how we discuss this. So this has been a really refreshing and open discussion. So I really appreciate that. And again, we've reflected the urgency of where we are. The reflection that this is a silent pandemic across Europe and the world that we don't see in the way that we saw COVID-19, for example. And we need to think creatively, and we need to think bigger in how we recruit policymakers and health leaders to join in and really prioritize this topic. The life course approach is something that we often advocate for as an organization, because we know that many of our lives are getting longer. We have the benefit of various health and other interventions that support us to live longer lives, but how do we make the best of them? And this is definitely, for me, it's been a really optimistic conversation of there is lots that we can and must, and in some cases are already doing, to make the most of these extra years that more of us have, and to really see the benefit and give people the opportunities without the barrier of mental health getting in their way. So that's been a slightly rambling reflection, but yes, thanks again to everyone for your time.
Thanks, Esther. That's great. We've got 10 or 15 minutes or so for questions, and I might start with there's a question in there around the role of family and relationships more broadly, and I don't know if any of our speakers want to talk a bit about sort of the role of family in helping support people tackle some of the challenges around mental health. Any reflections on that, Lord Layard, Baroness Ritchie, or Andres?
David,
Yeah, go on.
I agree that the family plays a pivotal role, but that's if you have a nice, neat, nucleated family that has all the help and support that it can give and has all the accessibility to the services that are required. But many of our families, and this is the reality of the situation, do not have that accessibility. So what support and what accessibility can be provided through policy initiatives and through direct government intervention to help those families and pump prime society?
Great, thank you. Lord Layard, you were on mute then.
Yeah, I was just going to say that, of course, your personal relationships are hugely important determinants of your mental well-being, and that comes out again in the kind of work that we do. So if I was giving a proper account of what are the main causes of low well-being, I would say after mental and physical health, family relationships, but also actually relationships at work can be very important for people's mental health, and to some extent, how safe they feel in their communities. All of these things are really important.
Thanks so much. We've been having lots of conversations in the office around sort of loneliness in workplace, and actually the move towards this sort of digital environment and the risk of the challenges of becoming more transactional and losing relationships, which I think is one of the risks of that. Andras, did you want to say something? I saw you came up for a second.
I fully agree. Sorry, I was muted. I fully agree. It's a very complex questions, and I fully agree with Margaret. So yes, I think education. There is also space for education, but also families are protective. To be in a family is a protective environment, but also with education we can help families to recognize much earlier the signs of mental problems, illnesses, the early signs. I think it's very important, and we talked about stigmatization also to highlight that talking about these conditions is not a shameful thing, but it's how we can help to our relatives, and I think through good initiatives we also can support families, and we also fight here in Hungary, my member state, to get more help for families. This is here a very relevant topic. They want to go deeper, from an opposite party, and we see that families do not get that support they need, and the mental conditions really affect the whole family. So yes, we need to put some more attention, and also to raise awareness among policymakers about this.
Thank you, Esther.
Perhaps as a final sort of thought on this particular question, when we mentioned the 155 million years spent in disability around the world every year already as a result of mental ill health, families and communities are already supporting those people. They are already playing that enormous role of helping people get through. And part of our advocacy in this space, and part of the way we want to change the world, is to support people with the literacy, with the resources, and with the confidence as well to help one another through serious mental health concerns that we've been addressing in this conversation. So it's an acknowledgement that there's plenty of people already playing these roles and doing this work, and all of that unpaid care can often go. It's difficult. It can be difficult to measure, or seen as difficult to measure. So that's a really key part of the change that we want to see as well.
Thanks, Esther. And I see George has put a link in the Q&A to the work that Wellcome have been doing in this space as well. And I should say, we have worked with Wellcome on this initiative, and they joined us at our event in Brussels. So they are doing some fantastic work in this across this broad space. We've got lots of questions which I'm not going to go through. Let me go back to the big politics one of most of our work has clearly been focused on, with this project, focused on the slightly wealthier countries. So we had China on the list as well, but clearly there is a big politics question around the UN General Assembly this year, where there is clearly an opportunity to get mental health onto the agenda more, but we also, as Baroness Ritchie mentioned, the UK reducing some of its global investment may have an effect here. US and its membership of WHO, and the US have led quite a lot of global mental health initiatives through their work directly or indirectly with WHO and USAID. Clearly, it seems to us that there are common challenges and problems, and we certainly, whether it be the UN General Assembly work or indeed the work at a European level, EU level in this space, there is a need for some global leadership. I don't know if anyone wants to reflect on the challenges we have with internationalism and the risks at the moment in that space.
David, you've quite rightly mentioned the role of internationalism in this particular space. I think the world order has turned around, and because we have a different person in the White House, US aid has obviously been impacted, but all of those decisions vis-a-vis Ukraine and Russia have impacted on our own budgets now, as we've just seen 30 minutes ago. The Prime Minister announced a reduction in aid spending from 2027 from 0.5 to 0.3. And remember that many years ago, that was at 0.7. Of course, there's a commitment given that to increase it whenever the funds become available. But that has been done in order to increase defence spending and to protect, I suppose, in conversations with President Trump in relation to the whole Ukraine-Russian thing. So we are all lost out on that. It does say that other departments are protected, but we'll know more about that when the Chancellor announces her comprehensive spending review next month, because all departments will find themselves in straitened financial circumstances, and obviously health is a big spending department, and that will impact on the provision of mental health. So I do think Richard and I have a particular role to do in the House of Lords in influencing our colleagues on the Labour bench and the Labour front bench to ensure that the provision of services for dealing with mental health conditions during the life spectrum are protected and increased in some manner.
Lord Laird, do you want to come in on that? You're on mute. You're on mute, Lord Laird.
I'm agreeing with Margaret. We used to have something called the Mental Health Investment Standard, which guaranteed that the share of total health expenditure going on mental health would be increased or certainly not reduced. And it's really important that that should be continued into the future because it's under threat.
Thank you. And Andres, do you want to say anything about the role of the European Union in potentially responding to these global challenges?
The world is changing, and I think, and I see this also in the European Parliament, that we have these populist parties, and they are very vocal about very they really spread also misinformation during the committee meetings, and it happened in one of my first committee meetings. I'm here new and it's not involved in politics till last April, and it was shocking to me that a lady from a far right populist party said that instead of it was a debate about monkeypox. She said that instead of sending medicines and vaccines to Africa, it would be better to have them improve their natural immunity. And I was shocked, actually. It was a clear shock to me. And my answer was that the infant mortality rate 100 years ago was between 15 and 20% in European Union, which means that 200 out of 1,000 kids died before their first birthday, and now it's less than 0.4%. And this is the result of treatment and vaccines, and what was 100 years ago, that's what natural immunity means. And I think these populist parties, they really don't care what they are destroying and what is the effect of their words, because they care only about popularity and how to be on the first page of newspapers. And it is a clear threat to our whole society and our healthcare systems. And I think the EU, the European Union, must respond. I think it's also a chance to realize the danger of these changes in the world, and to act faster and to secure our achievements in healthcare. But also it was mentioned that yes, the budget is always the topic, and now we have a war in a very close region, and it's also we must spend more money on defense. But I think healthcare is also spending in healthcare is also invest in our security, because it's about health security, and that's what is our role in the parliament. Talking about me and other MEPs with medical background and in some committee to underline this, that yes, there is a need to spend more on defense, but also spending less on healthcare it causes a really big danger to our whole societies. And we see that people with poorer health, they are also more likely vote for a populist parties. So to secure our democracy, I think is one of the keys is to keep the budget for healthcare systems. So Europe must react and analyze what's happening in the world, because if we hesitate or we don't have our solutions, that this will reach and have effect on the whole EU.
Great, thank you so much. We've got lots of questions still in the discussion, and we're not going to have time to go to them, but some really important ones on the role of the role of carers, and indeed the role of mothers in particular. Questions on how we prevent, and it's an interesting question around cultural differences. My colleague Emily has posited a question around a reason for optimism. So perhaps we could finish, I'm very happy if you want to answer any of those questions there that I've just flagged, but is there a reason for optimism? What makes us positive in this space about how things might change? And I know, Baroness Ritchie, you need to leave, so do you want to jump in straight away?
Yes, thank you, David. I think the area of optimism lies within the Darcy report, the National Health Plan, which is due out in the next while. And I think it's an opportunity to influence the government to ensure that there is a more holistic approach to mental ill health and the treatment of mental health conditions as part of the lifespan of individuals.
Thank you so much, and thank you for joining us, and we look forward to working with you as you go forward. Lord Layard, final.
Yes, I think that the basic reason for optimism is that the public has changed totally in terms of its willingness to talk about mental health problems and to demand action. And I think in the end, this will percolate through members of parliament, and it will lead to the kind of changes which we're all talking about. So I think this is probably a worldwide phenomenon, certainly a phenomenon in the English-speaking world. And incidentally, of course, it reflects enormously the increased role of women in public life. Women have always been more willing to talk about the inner life and feelings than men. And this is nothing but good will come of this. And I'm afraid I have to leave too, David. Excuse me.
That's fine. Thank you very much. And Andros Kolja, any final points from you? You're still there. We may have lost. Oh, there you go.
Sorry, I'm here. I had some connection issues. I just would like to thank for this discussion. It also was very interesting to me, and I also learned a lot. And I really hope that we can work together and to find solutions to these very burning issues, because it's about our future and the future of our societies. So thank you very much.
Thank you so much, and thank you for joining us. And we look forward to seeing you in Brussels at some point during the year. Thank you. Esther, can I ask you to any final reflections you?
Absolutely. So, as I mentioned earlier, I felt that this is a very optimistic conversation and approach to this very difficult and complex topic. So, as Patrick, my colleague, our research and development manager, who's co-led this project with me, and I conducted all of our roundtable discussions and one-to-one interviews for this program of work. We asked everyone we spoke to, what makes you optimistic? What is your reason for optimism? We want to show that there's light at the end of the tunnel. We want to take a constructive, bold, and positive approach to this complex and difficult topic. And everybody struggled. People really struggled in the light of the conversation we've often had, and the barriers and the challenges that we'd asked them to speak about. And then we'd pivot and say, what are you optimistic about? We made it quite difficult for people. But one thing that came up quite frequently is the potential for and ongoing developments of different pharmacological interventions, often predominantly psychedelic drugs. So there is our expert stakeholders would refer to groups of patients who had struggled to achieve any outcomes from other courses of treatment, and these so-called untreatables would have sort of another option and another path to go down to begin to manage and deal with the symptoms of their serious mental illness. So that's one of the exciting and ongoing developments that's happening in the UK and in to a lesser extent in the US and elsewhere. But my sort of final reflection is I'm glad we've had more reasons for optimism in this conversation than we did in some of our other ones. So many thanks to everyone for attending this webinar. Thank you very much to our speakers, and I'll hand it back to David.
And thank you, Esther, and thanks to Patrick as well, but also to the 100 or so people across the world we've talked to over the last year on this topic, and for you joining us today. We clearly we always see the launch of projects as the start of a conversation, so please do get in touch with your ideas and suggestions and comments of how we can collaborate. We are concerned and interested in how we can put mental health onto the global policy agenda, whether that be alongside the UN General Assembly this year or through the European Union or through other opportunities. So would welcome your advice and input into that. Clearly, there are some reasons for optimism. We've highlighted the need for government departments to work together, the need for a life course approach. The role of digital innovations has come up, and I think that's really important, as indeed, the role and need for, as Esther touched on at the end, as making sure we have better medications in this space overall, that we need to make sure that we're improving the sort of pharmaceutical, pharmacological solutions, but also making sure that people have access to talking therapies. And if we need to use digital tools to help people do that, then let's do that. Thank you. I'm going to stop there, but thank you all for joining us. For more information about our events coming up and indeed our research agenda, please go to our website at ilcuk.org.uk, and I look forward to seeing you at a future event. But thank you, everyone.